Perfect. Hi, everyone. Happy Friday. For those of you that don't already know me, I'm Alex Wilson. I'm an accredited mental health social worker and the Director of Mindful Recovery Services and the Central Coast DBT Centre on the beautiful New South Wales Central Coast. So today for our Lunch and Learn, we're going to be talking about dissociation, but we're going to be taking a little bit of a deeper dive because I've noticed that a lot of training around dissociation and working with dissociation focuses on grounding skills, and those are really important skills. But we're going to go a little deeper today and have a look at how we can actually, from a DBT perspective, work with the cause of dissociation to really stop it happening long term, right? So we'll touch on grounding, but we're going to go a little bit further. So let me share with you the Dropbox link if you want a copy of the slides. Let me get that for you. I'll pop it in the chat. There we go. If you want to follow along or you just want a copy for later, go ahead. If you have questions as we go, feel free to pop them in the chat as we go, and I'll pause every now and then to check in. And then at the end, we'll have some time as well. All righty, let's get going. Get my slides up for you here on the lovely Canva. Okay. Present mode. Here we go. Alrighty. So dissociation, going beyond grounding. As I said, we're going to take a little bit of a deeper dive today into how to target one of the really core underlying causes of dissociation without getting into trauma therapy. I'm going to touch on that as well. Okay, I always like to share this. It's dissociation, not disassociation. If you're a Harry Potter fan, you'll get that. So dissociation is a spectrum, okay? Mild dissociation is something that all humans experience pretty much. Mild dissociation is like, you know, you're driving in a car somewhere and you get there and you're like, whoa, where was I for like half of that trip, right? Our mind has gone elsewhere. That's very common, but that is a form of dissociation, right? So think about it as, you know, that mild, really non-harmful, non-problematic dissociation all the way through to the other most extreme form of dissociation is dissociative identity disorder. Used to be called multiple personality disorder, but now we call it DID. That's the most severe form of dissociation that we know about. And that's a psychiatric diagnosis. It's very, very rare, but involves, you know, extreme dissociation between different personality types. And then in the middle here, we've got a whole bunch of dissociation experiences. Derealization, depersonalization, dissociative amnesia, which is more up the severe end, but lots of stuff. In the middle here, there's lots of people that get dissociative symptoms with anxiety disorders, right? So when they're feeling highly anxious, they might get symptoms of dissociation that feel to them really scary and off-putting. So that's super common. We also see it a lot in conditions like borderline personality disorder, PTSD, complex PTSD, all that sort of stuff. So there's a big spectrum of it here. Some people, their dissociative symptoms come and go. You know, maybe they'll only have an episode of you know, mild or moderate dissociation every so often. Maybe it's only happened a handful of times. Other people, it's, you know, pretty frequent. It might happen every day at times, or it might happen pretty frequently. So when you're doing your initial clinical assessment, you're just going to take into account all of those different factors. I'm not going to go deep dive today into like the difference between derealization and depersonalization. It doesn't matter for the purposes of what we're talking about today. But the things with dissociation, when I'm assessing a client, I'm going to assume that they don't know the term dissociation, although plenty of them do, especially if they've been on TikTok for a while. But I'm going to assume they don't know that term. And I'm going to ask some questions around, like, do you ever have times where you feel like disconnected from reality, or you feel like you're kind of like out of your body watching yourself, things like that. And if they've experienced, dissociation, they'll say, yes, that has happened to me. And then I'll ask around, do you find that scary? What do you think that is? Because I want to get a sense of what they tell themselves about those episodes. A lot of people will feel like it's them going crazy. And that's really helpful to know in that initial assessment, because that has an impact, right? If our client thinks that they're going crazy, we want to explore that. So those are the questions I like to kind of ask around that, just to get a sense. Why does dissociation happen? Well, there's a bunch of reasons. We do know that trauma, stress, anxiety, different mental health conditions can certainly cause it. Again, highly correlated with borderline personality disorder and complex trauma. And again, it's different for everybody. How severe is it? How often is it happening? How does it feel when it's happening? Like how scary is it? But what we know is that dissociation really is an unconscious avoidance strategy that often starts as highly functional. This is really important because we're going to talk about doing psychoeducation with our clients about the functionality of dissociation, which is really helpful when we're trying to kind of get rid of the idea that, like, you're crazy, right? That it's actually a healthy brain thinking that it needs to avoid whatever's happening in the present moment reality. And that may have started for very good reason, particularly if we have people with trauma histories, right? And the other thing we're going to explore is that, the other cause of dissociation is a subconscious belief that experiencing distressing emotions is dangerous and harmful, right? So we're going to dig down deep into that today. This is a belief that may have started for people early on in childhood. Again, if childhood trauma is something that's happened, then this will be a belief that has developed. And we can work with that belief really effectively, which is what we're going to look at. So what are the difficulties when we work with dissociation? There's lots, right? There's lots. Sometimes if a client is dissociating in session with us, that can really interfere with us teaching and them learning new skills, right? Because if they're dissociated, I can't teach them anything, nothing's going in, right? So we do need to consider that. Sometimes dissociation can interfere with memory. It depends how severe it is, but on the more severe ends of the scale, memory can be affected, where when people are in a dissociative state, they may not be able to recall details from what happened when they're in that state. Again, it really varies, but that's something to keep in mind. Certainly, dissociation is going to interfere with processing of thoughts, feelings, and emotions. If I'm trying to get my client in session to identify emotions and they're dissociated, it's never going to work, right? Because their brain has decided it's not safe enough to do that. So we need to be aware. And sometimes we're going to know when our client is dissociated, and sometimes we're not. Right? It can be really hard to tell with some clients. And look, the more that you work with a client, you might pick up on certain facial expressions or certain body language that tells you that they might be dissociated. But a lot of clients hide it really well, and you may not know. So we need to, be checking in and having a look at how much in a session is actually getting absorbed, how much are they present for. Dissociation can be an unconscious therapy interfering behavior. Now, therapy interfering behavior is a DBT term, right? So if you've done any of my dialectical behavioral therapy training, you know that therapy interfering behavior is stuff that gets in the way of therapy being effective. It's not on purpose. The client's not even aware of it, but it's like the brain has decided we're not going to be present for this. And so it can get in the way of good things happening in therapy. So we want to become really aware of it, and we want to address it. And dissociation can coexist with life-threatening behaviors, right? So suicidality is very common, certainly in my clients who dissociate. We need to address the suicidality before we address the dissociation. I'm going to kind of explore how we might do that as well. All right. So in thinking about how we're going to tackle dissociation, we want to always remember our effective therapy pyramid, right? So first, we need to build relationship and safety, okay? Only once that is established are we then going to be able to teach skills, and only then are we going to see change, okay? So when I'm working with a client like this, if I go straight into teaching skills and I haven't established a safe therapeutic relationship, it's not going to work, okay? If that worked, people would just read a book about skills and then they'd be fixed, okay? It's not how it works. So first, safety and relationship, then skills, then we might start to see change. Okay, so let's keep that in mind as we go. So first things first, base of the pyramid, we need to create a safe and collaborative relationship, okay? So we have to have safety first, because otherwise that client is going to dissociate in our sessions. We're not going to be able to teach skills or concepts because they're not going to be present, or they're going to be in and out so much that we're going to really lose track of what we can do. So we first have to build this. During this phase, right, where we're building relationship, we can and should do psychoeducation about the functionality of dissociation, right? And we're aiming to understand it without judgment. Yes, Amy, I will be sending out a recording for those, as long as you registered through the website, or if you're in the DBT for Helping Professionals group, yeah, you'll get a recording. So, yeah, so during this initial phase, sometimes it's hard to know, like, well, what do we do then while we're creating safety in relationship, right? So it's all part of, obviously, the first session is like our initial assessment that may carry on into 2 or even 3 sessions, particularly if we've got a client who's quite high risk and we do get a sense that they're dissociating a lot. We might need to slow that assessment process down in order to meet them where they are. Because if I go into an initial assessment with a client who's highly distressed and dysregulated, and I'm firing all these questions at them, that might be too fast for where they're at. So I might need to space that out over several sessions. Just keeping in mind, you know, what I'm observing and what I'm feeling in the session. Are they with me? Are they not with me? Right? Pausing, checking in along the way, all that sort of stuff, right? And again, we always want to explore the problems really thoroughly before we even start to get into solutions. Now, there are some skills we can introduce pretty quickly, which I'm going to touch on next. But again, we don't want to bombard with skills and strategies right off the bat. They're not going to be able to hear them, particularly if they are dissociating a lot. So what I'd do is I'd pace my initial assessment in a way that feels appropriate to the client. I'd be checking in along the way, encouraging myself not to rush that, right? Because I know as therapists, we often feel this pressure, or just as health professionals, we feel this pressure to like get stuff done, give the client some solutions, but we need to slow ourselves down and make sure that we're matching where the client is at. For really dysregulated clients, just coming into a session with us, they're really triggered, okay? So they may already be, if you're aware of the window of tolerance, right? So the window of tolerance is where a client is experiencing enough kind of activation of difficult feelings, thoughts, etc., but they're not overwhelmed, right? This window of tolerance is where we do our best work in a therapeutic setting. So they're activated. There's enough yucky stuff that we're dealing with, but we're not overwhelming. When clients who are really dysregulated come in, particularly for an initial session, if this is where their overwhelm starts, they may already be here, right? Terrified, particularly if they have had unpleasant experiences in therapy before. We're going to cover that in the case study. If they have learned to distrust health professionals, if they have interpersonal trauma histories, right, they are going to be already so close to breaching that window of tolerance in that first session. So it may feel really slow to us, but we need to slow it down probably even more, okay? Or on the side of caution here. So it feels to us sometimes in those first few sessions that we're not doing very much, but actually what's happening is that we're establishing safety in relationship, Okay, it's like that duck where like on the surface it looks like not much is happening, but underwater it's like paddling furiously. There's a lot going on under the surface here, particularly for really dysregulated clients. Okay, so slow down, checking in with the client along the way, and don't put pressure on yourself to like get through the assessment and the checklist. You can space that out over several sessions. What we can start to do as well in these initial sessions is we can start to ask about dissociation. Again, those questions around, do you ever feel like detached from reality? Do you ever feel like you're kind of like, watching yourself kind of from outside your body, things like that. And clients say, yes, that happens to me. And then we can start to explore, what do you think that is? Why do you think that happens? Is that scary to you? And if they're starting to say things like, yeah, it's really scary, I feel like I'm going crazy, then we can start to educate, well, that sounds like dissociation. Let's talk about what that is. When we do psychoeducation, that's a really safe topic because we're approaching it from a cognitive level, right? We're not triggering, a ton of memories. We're not asking a lot about, deep-seated feelings. We're just asking and talking about kind of facts and figures. So I like to introduce that idea that, okay, dissociation is kind of a continuum, right? And, you may be somewhere in the middle here, but actually this is what healthy brains do when they feel overwhelmed. Why might your brain be feeling overwhelmed at those times? Can we see a pattern? Do you notice that this happens when you're feeling distressed or anxious? Yes, okay, great. So that's good. That's good for us to know, right? So we're just doing a bunch of exploring around that, but we're also normalizing this is healthy brain stuff, even though it feels super uncomfortable. What I'm also doing here is I'm sending the message that dissociation is not dangerous. Okay, that's a theme that I want to really be consistent with. It feels horrible, but it's not dangerous. Okay, it's just a brain going like, ugh, I'm going to check out here a little bit, right? So we're gonna put that theme throughout everything. So don't rush this first stage, okay? If it feels too slow to you, you're probably doing it right. Now, the next thing we're going to do is we're going to teach skills, right? Now, we do want to teach grounding skills, okay? Now, whether you call them grounding skills, if you use skills like, engage your 5 senses, 5 things you can see, 5 things you can hear, etc. Whatever grounding skills you like to use, by all means, introduce them. If you've done DBT training, we definitely want to introduce tip skills, right? So our tip skills are ways to, get through times of high emotional distress without having to fully avoid. We can use skillful distraction. We can introduce self-soothing, things like that. Okay, so these are basically like our crisis skills. And what we're doing here is we're giving our clients a toolkit. We're giving them an alternative to dissociation. We're going to get them to practice these skills, right? But we're still just treating the symptoms here, right? So these are really important. I want to do this before I get into the next step, but this is, again, just still treating the symptoms. So in the next stage, we're going to acknowledge and we're going to start to work on the underlying cause of the dissociation, which is this subconscious belief that experiencing distressing emotions is dangerous or harmful. The client's probably not even aware that they have this belief, but bet your bottom dollar they do, okay? So what we're going to do in this third stage now is we're going to introduce and explore myths about emotions. Now, this is a DBT concept. It goes into some other models as well, but I'm going to talk about it from a DBT perspective. And this is where we're really going to get into that underlying cause. And this is where we can start to get some really long-term change, where we're not just treating the symptoms of dissociation, but we're hoping to actually reduce the client's brain's need to dissociate. So, where do myths come from about emotions? Early messages from parents and carers, all very well-meaning, by the way, right? But messages that distress, unpleasant emotions are dangerous, bad, shameful, etc. Early childhood experiences and interpretations, very much so. We're all told as children that feeling bad is bad, right? That being angry is bad, that crying is bad, that being scared is bad. Like we're all told that, like the whole world tells us that, right? If the client has had any unpleasant experiences with strong emotions, that's probably feeding into these myths too. So particularly with childhood trauma, right? You imagine that as a child, you have an experience of like really intense fear, for example. In a child's brain does not have the capacity to, manage or understand those big feelings at that stage. They just feel really scary. So that experience can reinforce this belief of like, that's bigger than me, I can't manage that. Totally makes sense from a child perspective. But if you're dealing now with someone who's not a child, right, who has more of a frontal lobe available to them, we can start to challenge and change that belief. There are a lot of general messages from the whole world and society that feeling bad is bad, right? That it's shameful and bad and dangerous. So you don't have to look far to find these messages. And as I said, trauma will produce these myths stronger than anything. So this is nobody's fault, right? This certainly isn't the client's fault. And it's not, it's not caregivers' fault. It's nobody's fault. It's just what happens. It's just that the world is preoccupied with this belief that good people feel good and bad people feel bad, and you just got to like figure out how to feel better, right? And it's just not helpful, and it's certainly not true. So let's break down the main myths and how we would explore those with a client. So myth number one that I want you to consider is that negative feelings are bad and destructive. This is a very common myth that our clients may be carrying with them, right? That feeling bad is bad. And more than that it can actually like cause harm. It can be destructive in our lives. Now, the fact is there are no bad feelings, right? That's like a judgment that we've put on emotions, but emotions just are, right? And in fact, all of our emotions serve a purpose, right? That's why we have them. And they are part of being human. Feeling bad is really important as a human being. We actually need to feel bad. It's part of our survival. Think about fear, right? Fear is a really easy example of like, well, yeah, if we didn't have fear, we'd really be in trouble. Fear is a really important, unpleasant emotion that prompts us to protect, right? However, fear can get triggered at times where there's no actual threat, and so that can be trickier to manage. Even things like pain. So think about pain as an emotion. So painful, pain is painful. However, pain is an amazing motivator for change, right? So if we think about anybody that's ever left a toxic or abusive relationship, pain drove that, right? That's a good thing to get out of that, but painful. Anybody who ever has like kicked an addiction, pain drives that, right? People don't stop using because they're like, oh, I just don't feel like it anymore. They stop using because it's too painful to keep using. So pain is like so beneficial, but it is very, very painful. So you can see that this conversation really can evolve into a lot of deep talks about the purpose of individual emotions, really getting clients to identify, what are those emotions that they feel, so bad about, they feel are potentially so destructive. And let's start to look at what could be the purpose of those emotions. Why do we have that emotion, right? It may or may not be helpful at different times, but it may also be trying to say something important. We can't get rid of unpleasant emotions, but actually we wouldn't want to even if we could. So a really different way of thinking about it for a lot of clients. The other part of this, and we're going to delve a little deeper into this in a moment, but emotions themselves actually don't cause destruction. Emotions don't have a physical body, right? They can't go around smashing up the house. They're a felt experience. So emotions can't cause destruction, but what can is our attempts to avoid emotions, right? This is such a key point, and I'm going to drive this home in another myth as well. But basically, when a client says to me, no, but Alex, you don't understand, like when I feel really overwhelmed with pain, then I think about killing myself, and that's how emotions can, destroy me. And it's like, well, killing yourself, that's not your emotion doing that. That's you trying to get away from your emotion. It's the avoidance of the pain that can kill you. The pain itself just feels painful, right? This is a really tricky thing for clients, particularly clients that have experienced so much pain and have become so preoccupied with avoiding it. They feel like they have to, right? They feel like to survive, they have to engage in their avoidance behaviors. And their avoidance behaviors can be things like self-harm, suicidality, drug and alcohol abuse, disordered eating patterns, isolation, right? Anger and aggression. It's the avoidance behaviors that cause the destruction, but the emotions themselves, the most they can do is make us feel bad for a while, right? All emotions come and go, so they don't last forever. But this is something that a lot of clients get stuck in. And when you're exploring this myth and the other myths, you might find, and I certainly do, you have to have a lot of conversations and be a little bit like a broken record. Okay, well, let's explore. How could that actually hurt you? Walk me through that. No, okay, so that's your avoidance that could hurt you, but how could the emotion hurt you? Right? So it often takes a lot of talking and a lot of time for clients to start to agree, right? Because these are such deeply held myths. Another really common myth: painful emotions are not important and they should be ignored. So this myth really relates to this idea that, like, if we could just get rid of unpleasant emotions, life would be good, right? They serve no purpose. They're just getting in the way. They're just a pain in the ass. So again, we're going to explore here with a client, well, no, why might we have painful emotions? Okay, you're not bad for having them. You're human. Clients will sometimes say, yeah, but other people don't feel this bad. Well, they probably do. However, we want to then kind of validate, well, people mask, right? So people don't necessarily show you when they're feeling bad. But we also do know from the research that some people feel emotions more intensely than others, right? And there's perhaps a biological predisposition to that, where some people are born a little more emotionally sensitive than others. We also know that obviously trauma and upbringing and all those experiences play a role. But I like to validate that for some clients to say, it might be that you feel emotions more strongly than some other people. What are the pros and cons of that? So the downside is that pain feels a little more painful, or a lot more painful. But the upside to feeling emotion strongly is that people that feel that are often highly empathetic. And we see this, right, a lot with our really dysregulated clients, that they're highly empathetic individuals. If you look at people with, say, a BPD diagnosis, they're often animal lovers. They're often really passionate about animal rights and, other things that involve deep levels of empathy. And when they connect deeply, right? There's pros and cons to that too. But they have this really kind of big heart in there. So we want to validate that, right? And that's not something we can get rid of. We can't just get rid of the fact that you feel a lot. But could we actually acknowledge that this serves a really good purpose in some areas? But it does mean you might feel pain more strongly. So that's why we need this client to, really have great distress tolerance skills, right? Like Olympic level distress tolerance skills, because they do feel things really strongly, right? And so that helps to reinforce, like, okay, why are we doing this work together? Why are we trying to build skills, right? But so that we can still get the benefits of being emotionally sensitive, but we can manage the painful side of it. Yeah, but it's not a bad thing, right? So again, we're trying to challenge that judgment. We might get in here around the pain paradox, if you've heard me talk about that. The pain paradox is this thing that we know of, where the more we try and push away painful emotions, the more intense they will tend to get. This has been extensively studied, and I think we can all probably think about times in our lives where this has played out, right? And so we could start to explore this here with the client as well. We could start to say, all right, so I can hear that you've been trying to push away pain for a really long time. How's that going? Is pain getting better? They'll say, well, no, if they're sitting in front of us, clearly it's not, right? It's probably getting worse. So we say, okay, so it sounds like it's getting worse. So maybe what we can see here is that pain paradox, that I totally get why you're trying to push the pain away, but it actually, when it's coming back, it's like really overwhelming. Let's take a different tact then. Let's not keep trying to do that, because that's not working very well and it's feeling really crappy for you. Painful emotions want to be felt, right? In fact, all emotions want to be felt. That is literally their job. And if we don't make space for them, if we don't acknowledge them, they tend to just get louder and louder, right? Again, no judgment. None of us wants to be in pain. But actually, the way through painful emotions is turning towards, not away from, but in a safe way. So this is why we need them to have their distress tolerance skills or their grounding skills on board already. It's not fair to me to ask a client to approach pain if they don't have those crisis skills on board. It's not safe, actually. Because if at any point they start to feel really overwhelmed, I want them to know they have a toolkit that they can bring out to lessen that intensity, right? But once they have that toolkit, then how could we start to approach pain and start to actually see that we can cope with it, right? So you can see this could turn into a conversation that could go over several sessions. This is a really big area to explore. And depending on the response you're getting from the client, you could go down a few different roads, right? But the message overall is that we can't get rid of pain, but even if we could, that wouldn't be a good idea, okay? Let's have a look at myth number 3, and you'll notice there's lots of overlaps with these myths. And depending on what the client is saying to you, you might be able to identify, some of these myths more strongly than others, but they all might be there in some way, shape, or form. So myth number 3 is the belief that being emotional means being out of control. So there's this belief, right, that we're not coping if we're emotional. So when I start to explore this with a client, and if they say, oh no, but when I get emotional, I lose control. I ask them to paint me a picture about what does that look like? So when you're out of control emotionally, what are you doing? What would it look like? How would I know? What would you be doing? And they might say, well, I'd be crying. Okay, what else? I might be yelling. Okay, what would you be yelling? Oh, I might just be wailing. Okay. I might be rocking back and forth. Okay. I might be like scratching at my arms. Okay, interesting. Why do you do that? I don't know. It just helps me. Okay. So that might be a little avoidance strategy there, right? To try and minimize the intensity. Interesting. So what I'm getting here is a picture of what do they mean when they say out of control. And I'm going to start to differentiate feeling emotion and avoidance behaviors. Okay. So if we just sit with an emotion, and I'd say to my client, if you just felt that pain and you didn't try and do anything to get rid of it, you didn't try and minimize it, you just felt it, what do you think would happen? Well, I'd probably cry. Okay. So does that seem out of control for you? Yes. Okay, why is crying out of control, right? So we can start to really dig down and be humans cry sometimes. Maybe we could lessen the judgment on that. Maybe crying when you're upset is actually a really normal and understandable thing. Why does that mean out of control? If they start to go down the line of no, but then I start to do crazy shit, then I start to cut myself, or I start to punch things or whatever. It's right. So when you're doing that, is that a behavior that you do because it helps you feel better? Does it give you some relief? Yes. Okay. So that's an avoidance behavior, no judgment. But that's something else, right? That could be problematic. Again, here we could see avoidance behaviors can be problematic. But if you just actually sat with the emotion and didn't try to get away from it, would you still be breathing in and out? Yes. Okay. So that's my definition of coping. if you're breathing in and out, like you are coping. If you're wailing in the corner, rocking back and forth, but you're breathing in and out, you are coping, right? I know it's not fun. I know that we're like, oh, people are going to think I'm crazy or stupid or whatever. Fine. But you are actually coping, right? You're just feeling some really intense stuff, right? So again, we're just kind of unpacking a lot of that. And number 4, it's supposed to say 4 because clearly I can't count. This is a biggie. If I don't avoid or push away my emotions, they will kill me. So you'll find this myth is really prevalent for suicidal clients, right? Particularly those who have had chronic suicidality. They really believe that if they don't keep avoiding distress, that it will kill them. So we really want to explore this a lot. And again, touching on some of the stuff I've already said. So I'll say to my client, okay, so how could that emotion kill you? Well, it'd make me kill myself. Okay, so how would it do that? So it'd make me feel so bad that I'd have to kill myself. Okay, but the emotion, like an emotion doesn't have a body, right? So like an emotion can't like punch you in the face, right? Like it doesn't have a body. So how could your emotion kill you? No, but it'd just make me feel so bad that it would kill you. Yeah, but so there's a difference here, right? The most an emotion can do to you is make you feel really uncomfortable in your body physically, right? Because we feel feelings. So the most an emotion can do, though, is make you feel really uncomfortable in your body. But because emotions don't have their own body, they can't do anything beyond that. That's literally all they can do. That's the most power they have. Everything else is then us trying to avoid that feeling. So I'm sitting in my body, I'm feeling awful, and my brain starts to go, Alex, you could just get rid of this. You could just like end it and get rid of this. Well, that sounds like a good idea. That's me trying to avoid the emotion. That's not the emotion that does that. This is a point clients will argue with you on, right? So you're going to be like a broken record. And we're also going to be really validating here that this is really a big myth to challenge. Again, particularly for people that have been really preoccupied with suicidality and self-harm as well. The two often go hand in hand. I'm not saying the client is silly for believing this. So I need to put a lot of validation around this challenge. And if I feel like the client is really pushing back hard, I'm just going to go back to validate, like, I get that it feels really overwhelming, right? But I'm not going to validate that you have to kill yourself if you feel bad. I'm not going to validate that because emotions do come and go. And I might even start to explore with the client, you know, there have been times when you've felt really bad before and you've gotten through it. How did you do that? Right? So again, I'm using kind of evidence as well to say, well, you have sat through unpleasant emotion before, right? You've managed to do that. Doesn't that tell us that you can actually do that? So I'm trying to get a division here. I'm trying to make the client see that emotions themselves can't kill us. Avoidance can, right? Again, this is like a really tough thing for a lot of clients to get. You're gonna go through this a lot, you know. And again, lots of validation around it because we don't want the client to think that we think that they're silly or that this is like a basic thing that they should know. This is not a basic thing that they should know. The whole world tells us that distress could kill us. So this is really deep level stuff. And I'll validate that. I'll say, you know what? I understand this is really hard to hear because this is the opposite of what the whole world tells us about distress. So once we've identified the myths and we start to go into some challenging, right? But again, be really gentle with the challenging. If you get too much pushback, just focus on identifying the myths and focus on nurturing the relationship. But if we're able to do some challenging, then we can do that, okay? So first, we're just bringing awareness to the myths without judgment, no judgment, right? They're not silly or stupid for believing this. This is what the whole world teaches us. And I'll often validate, what I'm suggesting to the client is the complete opposite of everything that they've ever known. And that takes time to come to grips with, right? It's like unlearning everything that we've learnt through our whole lives. It's really hard. We can get them to use the check the facts skills. So again, like when I said, have there been times when you felt really distressed before, but you've managed to survive it? Tell me how you did that. That's a way of checking the facts of like, okay, that didn't destroy you. Clients who are really suicidal and self-harming, they're actually getting through times of distress quite a lot when they're not self-harming. So if we can identify those times where like they didn't do an avoidance behavior and they actually experienced the distress, we really want to validate that to be like, oh, so you managed to do that, right? So they may not be able to get through times of very high distress, but they might be able to get through times of a little bit of distress without avoiding. And we want to identify that so they know, like, actually, you do have those skills. We just want to build them up. Again, identifying behaviors that they do in response to the myth. So avoidance behaviors, what are they? We call them avoidance behaviors in DBT. Sometimes we call them problem behaviors. I don't like that term so much. But we want to do education with the client around, well, actually, we all avoid sometimes. And all avoidance isn't bad, but if there's avoidance behaviors that are like, really escalating and things like self-harm and suicide, then these, we do need to address these. They're potentially life-threatening, We want them to have skills, right? So again, we need them to have a real list of skills that they can use. So their grounding skills, their tip skills, their skillful distraction, their self-soothing, whatever skills that you teach, we want them to have a physical list on their phone, on paper, whatever, where when they feel overwhelmed, they can start at the top of that list and work their way down. And if they get to the bottom of that list and they're still feeling overwhelmed, they can just start again. We know that time will reduce distress. It always does, 100%. We just need them to use some skills during that time so that they're not making things worse. We could get them to write some encouraging statements that they can read back to themselves when they're in high distress and their avoidance urges are high. So again, it might be stuff like, you've got through tough times before, you can do this, or you're stronger than you think, or distress can't hurt you, or it's okay to feel bad sometimes, or, whatever it might be. So that and then they can kind of like read that stuff, have it on their phone or something, and they can read that stuff back to themselves. And most importantly, we just want to let them know this takes a lot of practice, right? Getting through times of intense distress it's not like a one and done. It takes a lot of practice. Our job in working with them is to identify small wins and to validate, right? So even like if I have a client who maybe self-harm is their problem behavior, their avoidance behavior, but maybe they managed to delay their self-harm. Maybe they did some skills first and they delayed their self-harm by 5 minutes. I'm going to validate that. I'm still not, stoked that they're self-harming, but I'm saying, wow, so like you managed to get yourself an extra 5 minutes. Well done, right? Because the client will beat themselves up incessantly. So we want to really identify things to validate. What we validate gets repeated. So that's why it's so important. There's a little template here, if you want it, that you can use with clients, just breaking down those steps, right? So, getting them to identify what emotion or experience they're having, put a name to it. Are they judging it, right? Are they judging that experience? And could they soften on that judgment a little bit? What myths about emotions could they identify? Get them to write that down once we've obviously done a lot of teaching around it. What urges are coming up? So avoidance behavior urges. What skills could they try? Now, if they're a very high level of distress, we want them to use something like tip skills, if you've done those skills, grounding skills, stuff like that. If they're at lower levels of distress, they could use other skills that you've taught. How could I encourage myself through this? So again, encouraging statements. And then, did I make it worse? If no, well done. Okay, because sometimes we're just trying to get through without making it worse. So this is just a breakdown where, you can work with clients to just build up those skills. And so dissociation, what we're doing here, right? We're also keeping an eye on dissociation, but because we're working with this underlying myth thing, once those myths start to shift, dissociation will reduce, okay? Because the brain is no longer believing it has to dissociate, right? So dissociation is an avoidance behavior, but it's a subconscious one, right? But because we're working on, building confidence to sit with emotions, the dissociation will start to go down. Let's have a little chat about Holly. Holly, 18. She was referred for counselling by her GP, past history of child sexual abuse, and a new diagnosis of borderline personality disorder. So Holly's someone we might say has a complex PTSD presentation. Holly has a history of suicide attempts and self-harm, so she's pretty risky. Frequent episodes of dissociation without amnesia. Okay, so she doesn't lose memory. She just feels detached from reality. She reports she often dissociates during therapy sessions in the past. And her episodes of dissociation occur when her distress is high. So when I'm mapping with her around like, when does this happen? It's always when distress is high. She was previously engaged in trauma-focused therapy, but her suicidality worsened and she disengaged after several sessions. So that's really common with highly dysregulated clients. Trauma therapy is not a good idea unless they've done a lot of work on emotion regulation first. Holly's currently on a gap year. She plans to go to uni next year to start a Bachelor of Social Work. She has deep levels of empathy, right, which is really common. She's living between mum and dad's house. Family relationships are pretty difficult. She has some supportive friends, but also relationships are historically pretty difficult. A lot of conflict in there too, which again fits with a complex PTSD presentation, right? Interpersonal trauma is an issue for her. So relationships are a big trigger for her. So the key things we can see in Holly's case, she has these past experiences of unsafe therapy. This is so highly relevant when we're working with her, right? It's going to take quite a long time with Holly to establish safety and to reassure her that we're not going to push exploration of trauma memories, right? Like if she wants to talk about stuff, go for it, but I'm not going to push that. I'm not going to introduce that. I'm aware the trauma is there. We're going to acknowledge it, but we're not going to get into memory exploration. So I wanted to feel really safe around that. She may also have beliefs that she's crazy, right? Again, so we want to do a lot of psycho-ed about the functionality of dissociation and some of her other symptoms. I actually wanted to know that her suicidality and self-harm makes sense given the amount of distress that she's sitting with. And none of that is her fault, right? So we're really trying to reduce judgment and stigma. Now, because she does have suicide risk, we do need to prioritize that. So we're going to work on that before we work on dissociation with her, right? Because we need her to be alive to do that work. So we're going to introduce distress tolerance skills with her pretty quickly. We're going to get, tip skills, all those sorts of crisis skills on board from a DBT perspective first, because we need to keep her alive. Once the life-threatening behaviors have stabilized, then I can go into my myths about emotions, right? That's going to be after that. So depending on how it's going with Holly, that's going to determine the timeline. I'm going to support Holly in exploring and challenging myths about emotions whilst validating why they have developed. Holly's going to have some real strong triggers around shame, right? Because of her history. So I just want to really always be sending that message of non-judgment and that even the most dysfunctional behavior makes sense when we break it down, right? We're going to encourage just lots of practice. This is not something that's going to change overnight. Practice, practice, practice. We're going to validate any and all progress, even small steps, right? And if I ever feel stuck in my treatment with Holly, I'm going to go back to validation and safety, right? And nurturing that therapeutic relationship. So I'm going to have to be really attuned to Holly. And when I'm feeling pushback, I might even ask her, to like check in around if she is experiencing dissociation in sessions and at what times. I want to keep an eye on that and keep an open dialogue about that. I'm also going to check with her between sessions. So when she comes in for her next session, I'm going to say, how did you feel after our last session? How was self-harming after our last session? If I see that problem behaviors have escalated after a session, I might have pushed too hard. I might have gone too fast, right? I don't want her to leave sessions and feel that she has to compensate by engaging in avoidance behaviors because we've done too much. So I always want to be checking in around that. Now, Holly's going to probably need long-term therapy. This is not a quick fix. So I'm going to need to be patient, right, with myself as well as Holly. Again, as helping professionals, we want to help, but we need to slow down with the Hollies of the world, right? Because again, remember, she's coming in, she's had a bad experience in unsafe therapy before. She's going to be highly triggered just being in the room with me to start with. So I need to slow down and I need to manage expectations. I need to tell her this is going to be a work in progress so that she takes the pressure off herself to fix this quickly too. Just to touch on, I won't go into too much detail about this. If a client does get to the stage, so say Holly, say I work with her, honestly, probably for at least a year before going anywhere near the trauma. But if she gets to the stage where she's like, I want to do some trauma work, right? And she's got good emotion regulation skills, dissociation has stopped, okay? I'm never going to do trauma work if there's still dissociative episodes going on, right? I'm never going to do trauma work if there are risky behaviors going on. The self-harm, the suicidality needs to have stopped and have been stopped for a while, right? I need to see that she's got good distress tolerance skills. I need to see that she challenges myths about emotions. I need to see effective emotion identification and regulation skills. And I want to do some pros and cons with her about doing trauma therapy again to say there are some risks involved, but there may also be some benefits. If I was going to do trauma processing with her later on, it would be, I guess, what we might call titrated trauma processing or client-led. I like to use the John Briere model, which is basically it is very client-led. So any resistance from the client is accepted. If the client changes the topic or goes off this direction, I just see that as healthy regulation. I don't challenge and push that. And if any of those problem things come back, if we see dissociation or self-harm come back, we stop, we go back to doing that other work, and we only go back to trauma processing if it's safe to do so. So the Hollies of the world may not ever want to do trauma processing, and that's okay. They don't have to, right? But if they do, I'm going to really, it's going to be down the track and it's going to need to be really highly monitored. Okay, I've put a little reference here for you guys. There's an interesting article about DBT for dissociative identity disorder. If you're interested in reading a little bit more about that. I mean, DID is super rare. Most of us will never see a true case of that in our career. But if you're interested in the DBT perspective of that, you can check out that article. All right. I'd love to hear questions, comments, niggles, anything that's yeah, but I'll give you a minute. Feel free to pop it in the chat, or if you want to take yourself off mute, please do so, or put a little hand up, your little hand icon, and let me know your thoughts. I'll give you a couple of minutes to do that. Any questions, queries, niggles?
I don't have any questions or anything, but I just want to say I really appreciate this. This is really valuable information.
Oh, no.
So thank you.
No problem. Thank you. I'm glad that's helpful. Yeah. Yeah. I mean, dissociation is something that, I've had so many clients over the years present with, and it's always been a bit like, oh crap, what do we do? Oh, no worries, Victoria. Yeah. So, yeah, I'm glad that was helpful. Okay. Last chance. Any more questions or comments? Thank you, Cheryl. Yes. Yes, that was my aim, to kind of explore it through a different lens, because yes, like the grounding stuff is super helpful. We do need to know that, but it's this other stuff that I found really helps that kind of long-term shift for my clients when we can do it.
Yeah,
All
I
right,
just wanted to say
perfect.
thank you. I think you really tied a lot together with the tip strategies, and then all the way through like trauma processing, grounding, all of that. So tied a lot together. Thank you.
Thanks, Jackie. I'm glad that was helpful. And thank you, Philippa. Perfect. So you'll all get a copy of all the things. If you have questions that come up, or if you want to talk about something, after this, feel free to drop me a line on the group or via email. I'm happy to chat through it more with you guys. All right. Enjoy the rest of your days, everybody, and I'll catch you soon. Bye.